we will deal with vital signs plus the instruments. Now we ask you to buy a kit because it contains all the essential elements to do a physical exam. We will now demonstrate the different parts, the different instruments that are in your kit. First we have the stethoscope, and the stethoscope consists of the bell is for low pitch and the diaphragm is for high pitch sound. You have a changeover mechanism to change from bell to diaphragm. You have the tubing, which should be 12 to 15 inches long, and then you have the portion with the earpiece, which should fit snugly in your ears, and it should be pointing forwards, not backwards. The next thing we have is your sphygmomanometer for recording the blood pressure. The essential part consists of the cuff containing the bladder, which extends part way, doesn't go all the way up from end to end. Then there is the tubing, and then there's the aneroid and the inflatable bladder that you put air in and release the air. Remember, the cuff, the bladder should be 80% of the circumference of the area that you put in the blood pressure cuff on, be it the arm or the thigh. They're normally 4 different size blood pressure, one for adult, one for the thigh, one for children, and one for babies. The next thing we will show you will be the ophthalmoscope. And again, it has different portions. There's the stem or the light source. There's the head, which contain your reflecting mirrors, and the wheels to control your diopter. And there is something to change your type of light that you're using. Remember, the battery should be charged every night in your set. Then we have the otoscope to look inside the ears. You have the stem again for the light source, and you have the head at which you attach disposable speculum to look inside of the ear. The next thing is your reflex hammer that you use for reflexes. You should be familiar with it from your neuroscience. Then we have the cotton swab, and that is when we want to do touch. You just roll the end into a fine wisp and you use it for touch. Then we have the tongue depressor. If you want to look inside of the oral cavity, you need to depress the tongue. Then we have the tuning fork. And we have 2 types of tuning fork. The 512, which is used for hearing, 128 that we use for vibration. The next thing we have is a measuring tape, and we use it for circumference or linear length measurement. Now you always should have a watch with a second hand so that you can time the pulse, respiration, etc. We have a ruler to get a straight edge, useful when we measure in the jugular venous pressure. Pen light, again to look inside the mouth or the nose, is any cavity that you want to look in. And you have a tourniquet, and you will use that when we doing things like the Trendelenburg test for peripheral venous system. And then we have a small eye chart. In the lab we teach you on the Snellen chart where you start at 20 feet, stand 20 feet from the chart. But this is a small chart that you can test, but you'll have to do it at a close distance. Okay, this concludes the different instruments that you will use during your physical examination. We next turn our attention to the vital signs, and vital signs consist of blood pressure, pulse, respiration, and temperature. In the lab we will not do temperature, but you should be aware that that is one of the vital signs. A 5th vital sign often added is pain assessment. Again, that is an observation which you will do as you examine the patient. The first vital signs we will discuss is the pulse. In the pulse, when you check the pulse, you have to check the rate rhythm, the volume, and the character of the pulse. Rate being the rate per minute. The rhythm, is it regular or irregular? The contour or shape, and the volume, of course, is the strength of the pulse. Normally we check the radial pulse as the pulse used to monitor these things. However, the character of the pulse is best by palpation over a large vessel like the carotid or the brachial. The other thing that you need to check in the pulse is the symmetry. Is it the same on both sides? The radial pulse, same on both. To do the pulse rate using the radial artery, it is done by palpating with your index finger and the middle finger. Both fingers are placed from the side to the radial side. Your most distal finger should rest at the skin crease of the wrist, and the fingers, you should use your palm to palpate, but your finger should be flat across the wrist. It should not be sticking in with your fingertip when you do the pulse. If you place your finger like that, you automatically will feel the radial pulse, generally in the area of your index finger. Okay. So having placed your finger in the right location, you will then count the pulse rate for 1 minute. It is sure a seasoned physician will count it for 15 seconds and multiply it by 4, but at your stage, you should palpate the pulse for 1 full minute. After counting the pulse, you should then put your other hand on the other wrist to check for symmetry. So you note whether the pulse rate has the same volume. When we talk about symmetry of the pulse, the only thing we refer to is the volume of the pulse. Because the pulse is generated by the heart, the rate and rhythm in all pulses will be the same. The only thing that can vary between two pulses will be volume if there is an obstruction in one. Okay, so you compare now whether the volume is the same in both. Of course, when you're doing the pulse rate, you'll have assessed the rhythm and you will have assessed the volume also. So the normal rate is 60 to 100 in the adult. Tachycardia is considered when it's over 100, and bradycardia when it's over 60. Remember, if the rhythm is irregular, an EKG is required. Palpate your right carotid artery, again using the same two fingers. Remember, you palpate in the lower third of the neck. Do not palpate high in the neck, because then you might massage the carotid sinus and the patient can get a reflex bradycardia. So palpate the carotid artery, trying to assess the shape of or contour of the pulse. Remember, there is an upslope, a plateau, and a downstroke. The upstroke should be quick. There should be a short pause at the plateau, and then the downslope should also be quick, but not as quick as the upstroke. Any abnormality in this should be noted. At the same time, remember, you have to test the rigidity or the state of the vessel wall, but we will do that when we measure in the blood pressure. Good. Measure the blood pressure. We have already demonstrated to you the instrument required. Remember, when you measure in the blood pressure, the patient arm should be at the level of the heart. Equipment needed for blood pressure is, of course, your stethoscope and your sphygmomanometer. The following is the method used for taking the blood pressure. We call it with 3 steps. We call it patient preparation, careful selection of the proper cuff size, accurate placement of the cuff, accurate position of the patient arm, accurate determination of the blood pressure, and blood pressure comparison one side with the next. Placement of the cuff. You will notice that there is an arrow on the cuff, and this tells you that arrow should lie over the pulse that you're in the area that you're doing. The first thing to do the blood pressure on the arm, you locate your brachial artery. Palpate in the lower third of the arm, the groove between the biceps and brachialis. Displace your biceps laterally, and you should feel the brachial artery. It is approximately, as I said, it's in the lower third of the arm. Next, place the blood pressure cuff over the arm. Approximate the lower edge of the cuff should be approximately 2 centimeters above the antecubital fossa. So with your arrow pointing over the blood vessel, make sure your cuff is snug. If your cuff is loose, you will not get the correct reading. So it should be snug. Okay. Next, you listen. You put your stethoscope in the antecubital space, antecubital fossa. You do not have to palpate the pulse there. You probably will not be able to palpate the pulse. But if it's in the right location, you will hear it. With the patient arm then at heart level, the first thing you do is to get the blood pressure reading by palpation. So one finger with the finger on the radial pulse, the other hand is used to inflate the blood pressure cuff, and you palpate the radial artery until you can no longer feel the pulse, and that will be the reading of the systolic blood pressure by palpation. You wait a couple of seconds after deflation. You do not want to inflate, and as soon as you let it go, inflate again. Because of reactive hyperemia, you will get a false reading the second time you try to measure the blood pressure. Okay, now place the bell. Now place the stethoscope, the bell, in the antecubital fossa. Inflate the cuff approximately 20 points above the level that you got the systolic blood pressure on palpation. Then slowly reduce your pressure until you hear the sound over the blood vessel. That level now is your systolic blood pressure. Continue deflating until the sound dissipates. It first will be muffled, then it will dissipate, and that's your diastolic blood pressure. So remember, you must deflate slowly, 2 to 3 millimeters per second. When the first 2 consecutive beats you hear is the systolic blood pressure, the sound will then become muffled and then dissipate, and that's your diastolic blood pressure. Good. Also remember to take the blood pressure sitting, lying, and standing. We will not demonstrate here now, but in the lab it's the same procedure in taking the blood pressure, but you will do it with the patient lying, sitting, and standing. When you change position, the patient should, for a minute or 2, stand or sit, as the case may be, to stabilize them before the blood pressure is taken. Up to 5 minutes, some recommend that you wait before doing the blood pressure in a different position. Normally, the respiratory rate is counted just after completing your pulse rate. So with the finger on the radial pulse, after counting the pulse rate, look at the patient's chest at the respiratory movement. Continue counting. The patient will believe that you're doing the pulse still, but you're looking at the chest movement. Count the respiratory rate for 1 full minute, and that will be the breath per minute.